Okay, and then the final part of the hypertension presentation, part 4, is going to deal with hypertensive crises. Okay? Hypertensive crisis is an elevation in blood pressure in which diastolic pressure exceeds 120 millimeters of mercury. In the rate of the rise of the blood pressure is more important than the numbers. Okay, it most often occurs in patients with uncontrolled hypertension or in patients who are non-compliant with their antihypertensive medications. This is the pathophysiology of what they believe causes hypertensive crisis. It's thought to be due to the endothelial damage, and which triggers the release of vasoconstrictors. Hypertensive crisis can be life-threatening because of the damage to target organs. And we do see that there is an increase in hypertensive crisis in patients, especially if they use illicit drugs such as cocaine and crack. So amphetamines, PCP, and LSD are also implicated in hypertensive crisis. As we mentioned, hypertensive crisis occurs most commonly in patients with a history of hypertension who have failed to comply with their prescribed medications or who have been undermedicated. But there are other causes of hypertensive crisis as well. And they are listed here, and we will talk about a few of these in more detail. Okay. So, in the presence of ongoing end organ damage, hypertensive crisis is referred to as a hypertensive emergency. Without such complications, it's referred to as hypertensive urgency. Hypertensive emergencies require blood pressure to be reduced within a few hours. The blood pressure in hypertensive urgencies can be lowered over a period of 1 to 2 days. IV medications are often used to treat these conditions. Some agents are used in the chronic treatment of hypertension, while some are reserved for hypertensive crisis. So the hypertensive emergency develops over hours to days. Okay? The blood pressure is severely elevated with end organ damage. The type of damage is listed here. There's all different types of damage that can be caused by these severely high blood pressures. It may be the central nervous system. We could have an encephalopathy develop. It could be an intracranial bleed. It could be related to the heart, leading to heart failure and pulmonary edema, even heart attacks. It may affect the kidneys, leading to renal failure. So there's all different types of complications as a result of these very severely elevated blood pressures. So here's a little bit more detail about the clinical manifestations of hypertensive emergency. One of them could be hypertensive encephalopathy. And in that case, we would see headaches, perhaps nausea and vomiting and seizures, and changes in level of consciousness. They could also display blurred vision or even a transient blindness. We could see renal insufficiency if there's damage to the kidneys. We can even see dissection of the aorta, and that it presents with severe chest or back pain, diaphoresis, and could even have the loss of pulses. Another sign would be a clinical manifestation could be cardiac decompensation with an unstable angina or infarction and pulmonary edema. Blood pressure alone is a poor indicator of how the patient is doing. it's not the major factor in determining treatment. Instead, it is the mean arterial pressure that is used to guide and evaluate treatment. Okay, so again, we bring up this equation for mean arterial pressure is the systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. This is what we are going to use to guide our treatment as we bring down the blood pressure in people who have hypertensive emergencies. Okay, so the goal of treatment is not the reduction in blood pressure per se. Rather, it is to decrease the end organ damage and the subsequent pathophysiology that occurs with sustained, untreated elevated blood pressures. The initial goal is to decrease the mean arterial pressure by no more than 25% within minutes to 1 hour. If the patient is stable, the target goal is 160 over 100 over the next 2 to 6 hours. Okay, lowering the blood pressure excessively may decrease cerebral, coronary, or renal perfusion, and this could precipitate a stroke, an acute MI, or renal failure. Okay, so that is we want to decrease the mean arterial pressure, basically 10 to 20% in the first 2 hours, in 1 to 2 hours, with gradual reduction over the next 24 hours. And we'll use IV medications to lower this blood pressure. While there are many medications that can be used to lower the blood pressure of patient in hypertensive crises, sodium nitroprusside is indicated and is the most effective drug for immediate reduction of blood pressure of patients in hypertensive crises. Okay, other drugs can be used as well. Okay, such as nitroglycerin, hyperstat, and apresyline. Even medications such as ACE inhibitors and adrenergic inhibitors. This is very commonly used. I've seen in the emergency room, physicians will order labetalol IV to bring down the patient's blood pressure in these situations. And Vasotec could also be used. So there are other drugs, but if you're ever asked which one is most effective, then of course you're going to go back to sodium nitroprusside, also called NitroPress. Now, these IV medications act immediately, really, very rapidly, within seconds to minutes. They begin working inside the body to lower the blood pressure. It's important that the nurse monitors the blood pressure and pulse. They always go together. We never just give one, but both parameters need to be measured, blood pressure and pulse. And you need to check them every couple of minutes. So then you can use a Dynamap, sure. You can have it set to inflate every several minutes because we have to monitor those vital signs very closely. It would be even better if we had arterial line. If our patient's in the critical care unit, then we may have an arterial line in which we could continuously monitor their blood pressure. Cardiac monitoring would be important as well. We talk about EKG monitoring during this time. And also we would want to look at hourly output, because remember that the kidneys, we need to make sure they're being perfused. When the kidneys are not being perfused, we're going to see our output decrease. So that's something that we would also monitor for. We also would do regular and frequent assessments on our patients. Any patient that is on an intravenous medication that's cardioactive, and being that it affects their blood pressure and heart rate, they need to be monitored regularly and frequently. So definitely regular ongoing assessment is essential to evaluating the patient with severe hypertension. Intravenous infusions of medications are commonly required in acute care medicine. And here we see a list of direct vasodilators, including hyperstat, apresilene, Lonitin, Tridol, and nipride. Nipride needs to be wrapped, these IV solutions need to be wrapped with an opaque material to prevent and protect them from light. They are only stable for 24 hours. Drugs like sodium nitroprusside, which is nipride, should be wrapped, and it will come wrapped in an opaque material to protect it from light. The problem with that medication is that it can be metabolized to cyanide, and so we want to make sure that we don't have prolonged administration of these medications. By the way, the word Tridol here, that's another name for nitroglycerin. That would be IV, intravenous nitroglycerin. Okay, so nitroprusside, also called nipride or sodium nitroprusside, it's all the same thing. Has its mechanism of action is peripheral vasodilation. It acts directly on the venous and arterial ulnar smooth muscles. Therefore, it can rapidly lower the blood pressure. And also, remember what we studied about blood pressure and cardiac output. So the nitrates, any drug with nitrate is going to decrease preload by causing peripheral vasodilation, and also decrease afterload by decreasing blood pressures. Now, this medication may produce cyanide poisoning if they have high dose intravenous therapy, which is greater than 10 micrograms per kilogram per minute, but also if it's prolonged administration. So if you administer it for over a long period of time, we need to be aware that nitroprusside may produce cyanide poisoning in your patient, especially if our patients have renal or liver disease, since these are the two organs in our bodies that are responsible for metabolizing these drugs. And if the drug is not metabolized efficiently, then it's going to increase in concentration in the bloodstream and can become toxic. So we like to just mention a few signs and symptoms of cyanide toxicity, and those include things like tinnitus, psychosis, confusion, seizures, coma, lactic acidosis. So there's lots of characteristics or signs and symptoms of cyanide toxicity, and I wouldn't spend too much time on it. They like to focus on this unusual characteristic of the odor of almonds on their breath. Okay, so almond breath could be a sign and symptom of cyanide toxicity, which could occur with nitroprusside IV administration over prolonged periods, or even in your patients who already have renal or kidney disease. So here's some more side effects of nipride. They're all listed here. I wouldn't spend a whole lot of time with that. But here we're moving on to another medication for IV administration, and that is hydralazine. And here are some of the side effects. Certainly when you have that vasodilation, it can lead to flushing. It can lead to flushing and also tachycardia. So it is an agent that can be used intravenously for a hypertensive crisis as well. Okay. I just want to mention a brief word about this medication, minoxidil or Lonitin. Yes, it has side effects like a lot of these drugs, potential side effects that could happen. But what I want to point out to you is that they discovered in using this medication to lower blood pressures that these patients also developed hair growth, hirsutism. Okay, so they marketed this product to balding men, and it does help for them to grow hair. So Lanatin has also been repackaged and marketed as Rogaine. Some of you may have heard of that medication. So it's interesting that the same medication that we use in the hospital to lower blood pressure is also sold as Rogaine to grow hair. Tridol, intravenous nitroglycerin, is used for the treatment of hypertensive crisis in patients who also have ischemia. So this is not uncommon. We see patients receiving IV Tridol. They do need to be monitored. They need to have their heart monitored during this process. Nitroglycerin, you are aware, causes venous dilation and lowers blood pressure. Okay, so of course the side effects can be hypotension. We already know about the headache when we use nitroglycerin, and they can also have flushing due to the vasodilation. It is administered by continuous infusion, and I guess that's mostly what you need to know about Tridol. We'll see its use again when we study our cardiac ischemia patients and heart attacks. So hypertensive urgency, we said, is different than hypertensive emergency because it develops over days to weeks, slower to develop. But the blood pressure is severely elevated as well, but there's no evidence of end organ damage. Therefore, we call it urgency versus emergency. Okay. Usually, the urgencies do not require IV medications. They typically can be managed with oral agents. They may not need to be hospitalized. However, it is important that they get follow-up care. Many drugs commonly used drugs for hypertensive urgencies are Capitan and Catapress. And here's a picture of Catapress, and you will see that there are different colors for different dosage of this medication. Again, it acts by dilating blood vessels, and it is used to treat high blood pressure, especially as an oral agent in our patients with hypertensive urgency.